During ASCO 2020 virtual, there were 3 abstracts which caught my attention. The first is looking at maintenance ivalimab versus best supportive care in metastatic urothelial cancer. The second was the DUTRENEO trial, which in a randomized phase 2 manner tests durvalumab and tremelimumab versus chemotherapy in muscle-invasive urothelial cancer. And the third study is the biomarker results of the Nvidia 130 trial, which looks at chemotherapy plus atezolizumab versus atezolizumab versus the control chemotherapy alone. At ASCO 2020, in the plenary session, I presented the Javelin 100 study. This study compared ivalimab, which is a PD-L1 inhibitor, with best supportive care in metastatic bladder cancer patients sequenced directly after chemotherapy. The hypothesis is that if you give chemotherapy first, you can get in control of disease in metastatic disease, get in control initially, and then give the immune therapy directly afterwards, and that then maintains that control achieved with chemotherapy. We feel that giving second-line immune therapy is too late for many patients, and therefore that's not the optimal approach. And we also feel that front-line immune therapy doesn't get in control of enough patients, and therefore giving chemotherapy first, getting control, and then sequencing ivalimab directly afterwards would be an optimal approach. We randomized 700 patients with metastatic urothelial cancer who had received frontline chemotherapy, 350 in each arm. We compared ivalimab with best supportive care, and we showed a survival benefit with a hazard ratio of 0.69, which translates to a 31% reduction in the risk of death associated with ivalimab. The drug worked across broad subgroups of patients, so there weren't subgroups that appeared it didn't work, and that include PD-L1 status, type of chemotherapy, response to chemotherapy. It also showed a progression-free survival advantage, and the drug was tolerable in line with what one would expect with immune checkpoint inhibitors in this setting. A large proportion of patients got second-line therapy in both the best supportive care arm and the ivalimab arm, but also a large proportion of patients in the ivalimab arm got subsequent immune therapy. So it was representative of the current clinical environment. And therefore, to summarize, the Javelin 100 study showed that maintenance ivalimab sequenced directly after chemotherapy reduced the risk of death in metastatic urothelial cancer by 31%. It worked in broad subgroups of patients, was well tolerated, and therefore is a practice, in my opinion, is a practice-changing contribution to bladder cancer. It's the first time we've had a positive randomized phase 3 study in urothelial cancer for survival in the frontline setting with an immune checkpoint inhibitor, and it's the lowest hazard ratio we've achieved in metastatic urothelial cancer, which is why I think it was selected to have a prominent place at ASCO in 2020. At ASCO 2020, the DUTRENEO trial was presented by Enrique Grande. This is an investigator-initiated trial from the Spanish group, which these trials are hard to do, and the group should be congratulated for performing this randomized phase 2 study in the neoadjuvant setting in muscle-invasive bladder cancer. The work that they've done is interesting because the primary hypothesis was in inflamed tumors, and those inflamed tumors have immune infiltrate. Those patients will have a higher response if they get immune therapy than chemotherapy. The immune therapy they selected was durvalumab and tremelimumab, which is a PD-L1 and a CTLA-4 inhibitor, and the chemotherapy was standard neoadjuvant cisplatin-based chemotherapy. The first part of the trial was to look at RNA signature associated with the hot tumor, or what I would describe as an immune inflamed tumor. And that was performed initially, and those tumors that were immune inflamed, that we think respond better to immune therapy, were then randomized in a one-to-one manner to receive the immune combination or the chemotherapy. The primary endpoint of the trial with PathCR, which is an endpoint that we regularly use, 22 patients were randomized into each arm, and the PathCR rates were 36% for the combination and 35% for chemotherapy. These data show us in this selected population with an immune infiltration, Deutronium, the immune combination, is not outperforming chemotherapy. An intriguing component of this data was they also, in the biomarker low patients with low immune infiltration, those patients received chemotherapy and they followed those patients as well, and they showed a higher response rate at 68%. When you pull this together, it builds on the hypothesis that we know already, that we can induce pathological CR rates with immune therapy in the neoadjuvant space. It suggests that the response rate is the same as chemotherapy, which is the current standard of care in a phase 2 trial, meaning that it's provocative for a randomized phase 3. But remember, and this is perhaps the most important thing, this is a selected group of patients. All of the trials are using it in unselected patients. And this selection is based on an RNA signature, not a PD-L1 signature. And so we don't really yet know in unselected patients what the activity of immune checkpoint inhibitors in combination from this trial. Previous data from Amsterdam and from Texas investigating CTLA-4 and PD-L1 in this setting have shown actually very encouraging data. And so I think this randomized trial builds on that, asks genuine questions about this particular biomarker. And again, this adds to what we know about immune checkpoint inhibitor combinations and biomarker therapy in the perioperative space in urothelial cancer. At ASCO 2020, one of my favorite bladder cancer abstracts was the work led by Matt Gowski and the IMvigor130 group. The biomarker group needs to be congratulated for their terrific work. The IMvigor130 trial was the largest study we've performed in metastatic urothelial cancer with 1,400 patients. It was a 3-arm randomized phase 3 trial, which was positive for progression-free survival. It compared chemotherapy, which was the control arm, with chemotherapy plus atezolizumab versus atezolizumab alone. The data presented here was the biomarker data, not the clinical data. We know the clinical data presented last year and published in The Lancet showed a progression-free survival advantage for the combination without yet a survival advantage in either arm. This work looked at different biomarkers. There are 3 key biomarkers, or many biomarkers, but 3 key biomarkers in this environment. One is PD-L1, the second is tumor mutational burden, and the third is the combination of PD-L1 and tumor mutational burden together. I'm going to start with the hazard ratios for the atezolizumab arm versus the chemotherapy arm. The hazard ratios in unselected patients was 1.0 or 1.02, showing no real benefit. But in the PD-L1 positive population, that drops to 0.59. In the TMB positive population, tumor mutational burden high population, that drops to 0.71. So both those biomarkers working a bit. But here's the interesting thing when you combine the two together, which turns out to be about 15% of the population, that hazard ratio drops to 0.22. Now, a hazard ratio of 0.22 from one where we started in unselected patients suggests in this exploratory analysis that if we use our biomarkers right, we can make a huge difference for these patients. The second really important finding in this trial, which I think is really intriguing, is with chemotherapy in the ITT population, chemotherapy plus atezolizumab had a hazard ratio of 0.83. That's a little bit, that's a bit better, going in the right direction. It's not yet significant. But then when you look at the biomarker population in the PD-L1 positive, that drops a little bit to 0.73, not as much as we saw, not that big a drop. And then with the TMB population, that only drops to 0.82. It doesn't drop at all, 0.82, 0.83, the same. So TMB not working. PD-L1 may be working a little bit, but not really. And then when you combine PD-L1 and TMB together, you get a hazard ratio of 0.88, which is back where we started. What this is suggesting to me in an exploratory analysis is that when you give the chemotherapy and the immune combination together, you're not seeing that enrichment associated with the biomarker. And it's beginning to ask questions about whether or not the immune therapy works as well as it could potentially when you combine it with chemotherapy. So in summary, this piece of work shows in a robust way, but in an exploratory analysis, the biomarkers working really well with monotherapy, allowing us potentially to select patients. But actually the combination, those biomarkers not working so well, and the question that we need to answer is the immune therapy being held back in those patients that overexpress the biomarker by the chemotherapy? This is going to be a hugely important question for us moving forward.